I'm Dr. Ariel Polanca, and you're watching The Step. Hi, welcome, Dr. Indu, to The Step.
Thank you for having me. I appreciate it, Dr. Blanca.
Absolutely. And I have to start out by saying happy birthday.
Thank you. I appreciate that as well. I am a year older and none wiser, as I like to say.
I highly doubt that. Well, it must be that you're so wise that you just can't get any wiser. Maybe it's that.
Let's look at it that way. Yeah,
Let's look at it that way. No, honestly, so honored. I know it's your birthday and you're taking the time to spend with us today. So honestly, thank you so much.
no problem.
So you and I taught a course together. We taught a fellows course, and you saved my life at a hockey game, for which I am forever indebted and grateful. But we really didn't get into our pasts and your journey, how you got into orthopedics. So I would love to just hear more about that. So if we could just start with that.
Sure. So, in terms of getting into orthopedics, as one of my partners puts it, it was a very simple choice. I got an opportunity to play with power tools and hang out with my friends in my pajamas all day, doing arts and crafts. So it's like summer camp with your buddies. No, but in all honesty, it made sense to me just intellectually and intuitively, just the physics behind it, the biomechanics, understanding why this screw pushes that bone in that direction. And so it came as a natural fit for me. Now, the more interesting question is also within orthopedics how one chooses a specialty, which is it was for me a difficult decision because, as I like to say, I'm an orthopedic dork. I liked it all, right? Except spine. No offense to any spine people, but I loved everything but spine.
You and I are exactly the same. I love it.
But then I reflected on honestly advice someone had given me long ago that is not even about orthopedics, just about life in general. And the idea was that find something no one wants to do, get good at it, and you'll write your own ticket. Combining that with the breadth of orthopedics that foot and ankle covers, it was, again, became a no brainer once I started to really, really sit down and think about it because I get the opportunity to be a sports surgeon, a joint surgeon, a trauma surgeon at my own discretion based on how I want to schedule my day. That was really what drove me into orthopedics and then also into foot and ankle.
Yeah. I just feel like you're taking the words out of my mouth. I get that question so often. Why did you choose foot and ankle? Why did you choose foot and ankle? And for me, it's just the diversity of the surgeries. I love my OR days. I love that I'm doing a total ankle replacement, a huge Charcot, and then an MIS bunion. I just love that, it's just not a total knee and a total hip over and over and over again. Like, we just have such a diversity, and it just makes it for like a really fun career.
Oh, absolutely. One of my old quips was, hip knee, kill me. It's like, I'd get so bored so quickly, I'd be done. And to your point about that diversity in the day, I mean, there are times when I have a case booked and I have to go back and be like, wow, I haven't done one of these in 3 to 6 months. I need to go, just double check my anatomy or double check my technique to make sure that I'm, really prepared for this. And that keeps it fun, right? That keeps the interest there on the day-to-day basis.
If this job doesn't work out for you, you can just write slogans or make t-shirts, by the way. You have a second. You have a backup job for you just in case. I think you're doing all right for yourself, but just in case.
Well, thank you. But Etsy, here I come.
And tell everybody where you're practicing now.
So I'm currently practicing at the University of Pennsylvania. I am in the Department of Orthopedics. I am the Foot and Ankle Fellowship Director, and just doing my best to be a good doc.
Awesome. And our kind of topic, or where we're going to focus today, is when you and I were talking, and I thought this was just really cool. One of your mentors had a philosophy that you had adopted. I'll call it the 7-year philosophy, and you've sort of modeled your practice around this philosophy. And I would love you to share more about that with us.
Sure. So it's a concept that extends beyond medicine and beyond orthopedics, and we all actually colloquially know it. It's the concept of this idea of the 7-year itch. And it is a true phenomenon. And what happens with the human psyche is that anything you're doing for X amount of time becomes normal to you. It becomes normalized. And so your level of interest, your level of attention to detail, all those things start to decline as this entity is normalized for you. So that translates then into a career where after every 7 years, you are likely going to be getting bored, or looking for some sort of transition or some sort of new challenge. And so what my mentor shared with me then was to think about my career in 7-year buckets, right? And this idea of what do you want for the first 7 years of your career, and then the next 7 years, and then the next 7 years. And they should be, as best you can, completely different focuses so that it re-engages you, right? It reignites you in terms of what you're trying to do here and keeps you involved in what you want to do every day. And I absolutely loved the idea. And the funny part is, whether because I was conscious of it or not, I don't know, but I can tell you that I definitely felt that 7-year itch and change as I was moving through my own practice. And for me, thankfully, that came right around the time that I found out about MIS and starting to move my practice over to minimally invasive surgery. And so I spent the first 7 years of my practice really focused on the idea of just becoming as good a physician and as good an orthopedic surgeon as I possibly could. Right. I was not, and to my own detriment, if you will, I was not interested in trying to be the most published. I was not interested in trying to be, the richest. I was very interested in, I want to master what this is that I'm supposed to do or I'm supposed to be good at. Right. And then from there, taking the next 7 years to focus on branching out now, right? Now that I feel comfortable in being able to say that, yeah, I think I'm at least decent at my job, right? Now I feel comfortable going out to now being able to teach, right? Going out to the idea of being involved with industry and expanding the concept of what's coming out for new devices. Getting more into research and publishing now because I feel I have the experience to be able to say, I believe, and this is what I've seen. This has been my experience, rather than jumping into it within the first year. And interestingly, I also switched practices right after that 7 years as well. And
So you took this seriously.
oh, absolutely, absolutely. But the funny part is that it also happened fairly organically. It wasn't like at year 6 I was like, all right, next year I got to get these things. It just kind of happened organically, and I realized where I was in my career, and I was like, I am starting to get a little bored. I am starting to feel like, I can just walk in and do whatever case, and that's, perhaps not in my own interest or even the patient's best interest at the end of the day, right? That little bit of what we like to call sphincter tone is absolutely essential to a good outcome, right? That keeps you on your P's and Q's. And so revitalizing my practice, my career, the way that I'm doing things, reinstituted that bit of sphincter tone, right? So that now I am prepping for every case, right? Because I want to make sure that I'm still as good as I think I am, and doing all these other things at the same time.
Talk to me about, that mastery, that first 7 years where you were just taking that time to master, like you said, being the not only the best doctor, but also the best surgeon. How did you accomplish that? Like, what was your technique, your mantra? Like, how did you do that?
Sure. So in terms of it, you have to evaluate yourself objectively, right? And there's no better objective measure than your patient's outcome, right? And are you having a multitude of complications? Are your patients happy? What are your patients' reviews of you, right? Because at the end of the day, that mirror they hold up to your bedside manner and to your bedside treatment is real. It is a reflection of what you have done and accomplished in the room, right? Their outcome surgically is real. It's a reflection of what you have accomplished in the operating room. And so to me, to define that mastery, then it was based on what are my patient reviews, what are my patient outcomes, and what are my complication rates. Now, we all have excellent patient reviews, to whatever extent and level. But for me, I set a goal. And so I'm somewhere around, and not to be braggadocious, but the idea being, right, so looking at the objective number. So on our website now for Penn, I have somewhere well above 800 reviews, and I'm at 4.99 stars, right? So to me, then cool, I'm doing what I'm supposed to be doing in the room with the patient, right? In terms of my patient outcomes, the reviews say I do okay. Patients seem to be pretty happy, right?
Seems like they're pretty darn happy, Bobby. I think we're doing okay.
Yeah, and the hospital hasn't gotten rid of me yet for infections and complications, so I think I've done okay in that regard. And so that's where, again, this idea of starting to feel very comfortable in your own skin and in what you're doing. And we all go through this, and this is one of the things I actually share with trainees, as now being on this other side of teaching. Everyone on some level goes through some concept of imposter syndrome as they begin this process, right? When you started out as an attending your first 2, 3, 4 years, you questioned yourself at every decision you made. Did I do the right thing? Was that the right choice? or if you didn't, you should have at least say that, right?
Hmm.
And to arrive at the place of comfort with it is again when you start to arrive at that level of mastery with it, right? Your outcomes are now speaking for themselves, so you feel comfortable in your protocols and in how you set things up. Um, and there is no substitute for the time that it takes to accomplish that. Malcolm Gladwell and this idea of 10,000 hours, I think that that's not exactly accurate. I think it's been proven to not be accurate, but there is something behind the concept of doing it again and again and again until you have it mastered.
Until you have it mastered, that repetition. Yeah. And how has that evolution from, learner to teacher? How has that been for you?
It's actually it's pretty fun, right? And so I again to this idea of I admit entirely that I'm an orthopedic dork. I love learning about it. I love reading the stuff. I love the conversations. One of my favorite things is conference. And so in that orthopedic dorkdom, it also turns out then in terms of teaching, it's like being a parent, right? Like when you get to see your learner like grab a concept or when you see their mind blown by something, it's like, yeah, I know, right? This is pretty cool, isn't it? It reinforces or reinvigorates for me that idea of like, this is why I do this, right? Orthopedics is really cool and really fun. Um, there's a great quote that used to hang over the surgeon's lounge at my old job. And it was just a small little, 9 by 11 page, and someone stuck it up with a thumbtack. It was a quote by Harvey Cushing, and it said, any surgeon who fails to teach their pupils to the best of their ability has done a disservice to humanity. And I always took that to heart. One of the things I read it the first time and it really struck me, right? Because if you don't love the teaching, if you don't want to do the teaching, if you're not engaged in the teaching, then you're preparing somebody half-heartedly to go out there and now teach others and take care of people. So you will create this tree branch of poor care, right?
That's on you,
Yeah,
right?
just you
That's
didn't
on
do your job,
you.
right? It's a
Yeah.
legacy of poor care that you will create unless you do your best. And again, though, I don't know that I would have had that concept or that desire, that feeling in my first 2, 3 years of practice, right? Because I was just trying to make sure I did okay and patients did all right. Now, again, being comfortable in that phase, now I can focus on, all right, you have to learn, right? I need you to try this. I'm going to watch you and watch you do it and then make sure you're doing it correctly. If not, I can step in. Or if you don't do it well, I know I can correct it. And that transition takes time. At least I firmly believe.
Does it make it more complicated now that you are kind of adopting these new techniques, technologies, MAS, et cetera? So now you are doing these new things, but you have trainees. Does that make that teaching a little harder because you're not doing those things that you're such a master? I mean, you are a master now, but in the beginning with the repetition, how did that change your teaching style?
Oh, absolutely. Absolutely. I mean, in this thing that we do as medicine, it is technique and art, right? No question. Um, the technique you cannot teach until you have mastered yourself. And so when I transitioned to doing mostly MIS, I was doing the majority of the case, no question. And it was more about the trainee watching me, right? Put your hand on my hand, or my hand is literally holding your hand as we're manipulating the burr together. Um, and again, until I feel absolutely comfortable, I can't let go of the burr, right? And that's not any sentiment about the trainee. It's about the responsibility I have to the patient, right?
Uh, 100%.
Right. And
Yep.
so that comes first and foremost above anything else is our responsibility to the patient, then our responsibility to our trainees. And I think any trainee themselves would understand that. And I think ourselves when we were trainees understood that, like, look, I'm talking to your attendant as a resident, talking to my attendant, hey, yeah, I'm gonna give you back the knife for this part because I feel like you should do this, not me, because I'm not ready yet. Right? And there's no shame in that. I think that again, that highlights that our first and foremost responsibility is do no harm. Right. And if do no harm means that I'm the best equipped to do this right now, then I should do this. And that still has to be front and center and front of mind, even when training.
Tell us your journey to MAS. Like how I know that that was what that 7-year bucket kind of shift was, but how did you get there?
Well, I have to give a shout out to Dr. Chris Miller for that. If I'm ever going to talk about how I got into MIS, so Chris Miller, myself, and Paul Toulouse and Alan Ferrucci were all residents together at Yale. and we all went into foot and ankle. Chris is at the forefront of MIS here in the States. And we're all on a text chain together. And when Chris started doing MIS, he would send us crazy x-rays and be like, hey, I did these, cool cases through these little poke holes. And all of us were like, oh, that's wonderful, Chris. That's great. Yeah, never
Yeah.
gonna do that. Yeah, ever. But he is a persistent fellow. And so he kept sending things. And then after a while, I started seeing the literature on it. And so I talked to him. And he was mentioning that, he's seeing really, really good outcomes with it. And I should really consider it. And so I did a lab. And the lab went terribly, just
Oh,
awful. Oh, I missed every wire possible. And then I was like, I don't know that I'm going to do this. I don't know that this is, for me. Did another lab, and I actually trained for almost 2 years before I touched a patient with it. In terms of just doing labs over and over until again I felt comfortable with it. Then I actually took a day and went down and spent with Holly Johnson, where she again took me through how she did things and what happened there. And Holly gave me great advice that I, like a moron, did not follow. She told me for your first case, which I had coming up a few days later, she said, book it for 3 or 4 hours. And I was like, I don't know, Ali, it's a lot of time. I feel like I can get it done a lot faster than that. So, 4 hours later, I was,
yeah.
cussing to the wind, all sorts of things. And I was like, she knew what she was talking about. But point being that it was a steep learning curve, but an absolutely fun one, a worthwhile one. And now the majority of my practice is MIS. I do forefoot, midfoot, hindfoot, as much as I can with the burr, because I think it gives us far better outcomes for our patients, less injury to our patients. And frankly, it is the future of foot and ankle. And I think beyond foot and ankle, into other areas of orthopedics.
Yeah, I agree with you. Yeah, my story is it's different but equally as funny. I hated bunions. But why did I hate bunions? Because I wasn't getting reliable, wonderful correction. And intraoperatively, it was a 20-minute case or it was an hour and a half case based on bone quality and deformity and what resident I was working with. And so when MIS started, my buddy Dan Toulier, who was at UCSF, this was when I was at Stanford, and I made a pact that we would never learn it because we saw it as the future. And I thought that I wouldn't have to do a bunion again because a patient would come in and be like, ooh, sorry, I don't know MIS. So you're going to have to go somewhere else. Well, turn back time, moved to San Diego and started private practice. And I was like, well, this is probably going to be a part of my practice. And now it's my workhorse. So it is kind of funny how these stories and our colleagues, our little packs and our text message threads end up influencing us a lot. So
Absolutely, absolutely. And it also highlights the idea too that I think, a lot of people, when you're coming through this, and you always ask people about, oh, I want your career, I want to end up how you ended up. How did you figure that out and plan? And it's like I actually didn't plan anything, right? It kind of
mhm.
fell into the hazards of it as we went along. And I was advised of that coming up, but I always thought that I had to have a plan. Now I see that it doesn't work.
And you can have a plan, but doesn't mean you're going to follow that plan. It doesn't mean that plan's going to pan out.
Mike Tyson was right.
Yep. Now with this like kind of evolution of your physical practice, did you have like an evolution of like your theology behind orthopedics or just the way you approached orthopedics, the way you approached patients, your practice of medicine, or did it really just kind of come in like the technical side?
No, I would say there's definitely been an evolution in my approach as well. I think that, and again, for all of us, we have to go through our own course of it. I think in the beginning I was much more focused on the disease, whereas now I think I'm much more focused on the patient. Where before I also, I would want to please the X-ray gods and make sure that I had the perfect angles and my screws were the right depth and the threads were everything's right across and chef's kiss. Um, yeah, but it didn't make a difference. Right? And so now, not to say that accepting nonsense, but you know what I mean. I think that I don't try to please the X-ray gods anymore. I'm trying to make sure that my patient has a really good outcome. I think in my approach now, one of my students pointed out to me one day, had a patient that was just a bit challenging and kind of all over the place as we were going through things. And so to hone it down, I just simply said, all right, at the end of the day, what is your goal? Like, what is it that you want? Like, all this other stuff aside, in one sentence, what's your goal? Right. Whereas before, I think I would have been more along the lines of, yes, we can fix that hammer toe and get the angle just correct and 27 different points to what we're going to do for you. What do you want out of this? and then let's just take it from there. So I think that that evolution in my approach has come from maturity, time, and understanding that sometimes what I think is perfect isn't what the patient thinks is perfect, right? And at the end of the day, what they think is perfect is what matters the most because they're the ones that have to live with it. And that has come with that evolution in time as well.
And I think, MAS surgery, I think that that has helped, at least for me, be able to divorce myself from the X-ray, the X-ray judgment. I got like really great advice at an MAS conference once, and it was just like, if your patient has ankle arthritis and is coming into you for ankle arthritis, are you getting an X-ray for the every 2 months or 3 months they come in for a cortisone injection? No. And if your patient's happy and they're pleased with their forefoot correction, like, are you just getting x-rays like every time they come in to just like look at that, the delayed bone growth? And no, there's really no need to if your patient's happy. So I think MAS has also helped me at least a little bit be able to say, is the patient happy? Like that's the goal. And so I completely agree with you because what are we here for? It's patient satisfaction, right? That's what we're trying to do, not to make us feel great that our x-ray looks fantastic. It's to make the patient feel fantastic.
It's fine. I think that's a great point you make about the MIS divorcing you from the happy X-ray concept because, as I mentioned, the original X-rays I saw, I thought they were so crazy, right? And then even now, when I'm teaching residents, fellows, or students, I explain to them, all right, we're putting up the even patients, we're putting up the X-ray. Bones look, like a puzzle pieces, but that's not what you're looking at. What I want you to look at in terms of is you want to look at the skin edges, right, and see what the outline of the foot is, and see how much of a correction you really got here. And so again, that idea of divorcing yourself from what our classic teaching of what the bone should look like versus what the outcome should be.
When I first started doing MAS, I took a picture of what an MAS bunion x-ray looks like, and I showed it to all my partners because I'm like, this is what I'm trying to do. Just letting you know. Like, this is actually what I'm attempting to do. This is the right move. So just in case you see an x-ray of mine and you just don't think that your new partner is a total hack, like this is the goal. They're like, all right, whatever you say.
So that's why. So a couple months ago, I was working with a new scrub tech at one of the outside hospitals, and I finished up a bunion, MIS bunion, and we're asking for the suture, and we're starting to close, and she's like, "Oh, you're closing. You're leaving
You're
that
done.
like that."
She's like, you're done? I
There's
love
not
it.
more to this.
What do you see in your next 7? Like, we had our first 7. I love it. Like, we had our mastery. We have our mastery 7. And now it sounds like we have this branching out. We have our innovative 7. What do you think the next 7 holds?
So, in terms of for myself and my career personally, I think that the next 7 after this will hold, hopefully, the idea of really development, right, and producing the next generation of what foot and ankle should be. Um, because then at that point, I feel like I've done the work. I've learned the business, and then the idea is to put them together, right, and create what the future should be. And I think that's what all of us should attempt to do as we age out in this thing, right, is set up the next generation of folks for whatever greatness should be. Because we came in on someone else. So when I started this, I came in on someone's coattails, and at that time total ankles were kind of just rearing their heads as being the next thing, right? Now they're fairly ubiquitous. Now MIS is coming up, right? I think that the next thing is going to likely be robotics and navigation in terms of foot and ankle. What we're seeing in hips and knees, we'll now start seeing in total ankles, and perhaps even some of our own deformity correction work.
Hmm.
So I think that those of us who are going to be on the way out when that is on the way in need to really be working on developing that for the people coming after us.
That's really cool. Well, on that note, I wish you a very, very happy birthday. I wish you a really fun time in this next 7 years of innovation. And I'm really looking forward to that following 7 years of development. And hey, who knows? Maybe we can figure something out together.
I'm with it. I'm always happy to work together. Thank you for having me. I really appreciate this, and
This
you
was
are a wonderful host.
this was such a pleasure. And to all our listeners and viewers, thank you so much for joining us today, and we'll see you next time.